The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone. My name is Tiara Brooks from School-Based Health Alliance, and we would like to thank you all for attending today's informative webinar on the key findings from the FY 2014 State Policy Survey. We have a few housekeeping reminders before we get started today. If you are viewing as a group, please go to the chat window and type in the name of the person registered and the total number of additional people in the room. For example, Tammy Jones +3. This will help us with our final attendance account. We also have just a few reminders. All attendees are in listen-only mode. To ask questions during any point of the webinar, please use the chat box, which is located in your GoToWebinar control window. We will address questions following the presentation. Also, this presentation is being recorded. Attendees also will be asked to complete evaluation poll questions at the end of this webinar. Please let us know how we are doing. Your feedback is vital in helping us craft presentations that meet your needs. This presentation will be archived and will be uploaded onto our website in 3 to 5 business days. Also, if you would like to view additional archived webinars, please visit our website, www.sbhforall.org/webinars. We expect by the end of this webinar, you will be able to understand state-level school-based health center funding and trends, identify state policies pertaining to Medicaid and school-based health centers, identify most frequently tracked performance indicators by state public health departments. Now I will introduce my colleague and our presenter for today, Suzanne Mackey. Suzanne joined School-Based Health Alliance in March 2014 as a policy analyst. In this role, she is responsible for federal, state, and local school-based health center policy research, analyst, and advocacy. Suzanne has a background in federal public health policy and advocacy, including previous work with the National Coalition of STD Directors and the AIDS Institute. Now, I would like to welcome Suzanne Mackey.
Good afternoon, everyone, and welcome to the webinar. I'm excited to share with you some of the highlights and key findings of the fiscal year 2014 State Policy Survey. As many of you probably know, every 3 years, the School-Based Health Alliance surveys state health departments and Medicaid offices for school-based health center funding information, accountability standards, performance indicators, and Medicaid policies. For those of you outside of the SBHC field and are not as familiar with the model, school-based health centers provide children and adolescents access to health care in a location that is safe, convenient, and accessible, their school. They are staffed by licensed professionals with the expertise and experience to deliver quality care that addresses the broad range of concerns that affect students' healthy development. The services SBHCs deliver improve the social, emotional, and behavioral health of students, as well as minimize the effects of poverty and other adverse experiences on their school success. I want to begin by sharing a map of SBHCs nationwide. This map shows the growth by state of SBHCs since 1998. You can see the total number of SBHCs in each state according to our most recent census data, as well as the percentage of growth in each state since 1998, which is color-coded. While the block of western states in white, for example, are very new in their SBHC growth, states such as California, Florida, and Connecticut have seen an over 200% increase in growth since 1998. As I mentioned earlier, separate from our state policy survey, We also conduct a census survey every 3 years where we seek to collect data on all SBHCs across the country. As you can see, the field has grown steadily since the late 1990s. For the school year 2013-2014 survey, 1,900 SBHCs responded to our survey, which is a completion rate of 82% of all known programs. We attribute much of the increase in SBHCs from the 2010-2011 period to the 2013-2014 period to the construction and renovation funds provided through the Affordable Care Act. As you may know, in 2010, Congress appropriated $200 million for fiscal years 2010 to 2013 for the construction, renovation, and equipment needs of school-based health centers. From our census survey, we know that 70% of school-based health centers report receiving some state funding. Within that group, 40% of all school-based health centers receive dedicated funding from a state SBHC program office. As you can see, state funding overall is a critical source of support for SBHCs nationwide. The state policy survey consists of 2 separate surveys, one for the state SBHC program office and one for the Medicaid office. There are currently 18 states that report funding an SBHC program, and we only asked these states to complete the survey. We confirmed with all other states that they currently do not fund an SBHC program. We received completed surveys back from 17 state program offices and received partial data from one of our state affiliates where we could not reach the program office. For the Medicaid survey as well, we also only requested survey completion from those 18 states with confirmed SBHC programs. We received completed surveys from 15 state Medicaid offices. This is a map of the 18 states with an SBHC program office, noted by the stars. And now you can see the growth of states over time and whether or not they have a program office. As you can see, some of the states with the largest growth over time do not have a state program office, and I will discuss this a little bit later on. Before we dive deep into the funding data, here is a broad overview of state-directed funds for FY 2014. The total amount of state investment for FY14 was $85.1 million, which is a decrease of $4.5 million from FY 2011. This includes a total of 915 SBHCs funded through state programs. On the high end, we have Michigan with total state funding of $13.5 million, which supports 218 SBHCs. And on the low end, we have Indiana with total state funding of $200,000, which funds 2 SBHCs. On average, state investment was $4.7 million, with 51 school-based health centers funded. Looking at the breakdown of funds by source, you will see that state general revenue continues to be the dominant source of funding, accounting for 80% of total funding. The other category, in dark brown, includes the Medicaid match, which is a source of funds in Michigan and New Mexico, and the Social Services Block Grant, which is a source of funds in Illinois. Title V MCH Block Grant and Tobacco Settlement Funds constitute the remaining sources of funding. This table breaks down state-directed funding for SBHCs by state and source. On the left side of the table, there is a column for total SBHCs funded by each state, which was reported by the State Program Office survey. And to the right of that is the total number of SBHCs in the state. These numbers are from the 2013-2014 Census Survey findings. And the total of 2,315 SBHCs at the bottom of this column is the nationwide total, not just the total for the 18 SBHCs with the state program office. You can see that in some states, nearly all SBHCs in the state receive dedicated state funding, such as Delaware, Oregon, and Maryland. And in others, such as Texas and North Carolina, only a small portion of SBHCs receive dedicated state program funding. The top 3 states with the largest school-based health center programs are Michigan, Connecticut, and New York. These are the same top 3 states in the FY 2011 survey. Even though both Michigan and New York experienced decreases in funding since FY 2011, they still remain in the top 3 states for FY 2014. To take a historical view, we can see over time that state general revenue, in light brown, has always constituted a majority or at least a significant portion of state funding. Tobacco funds, in light blue, were at their height in FY 2002 and have declined since then, and significantly so between FY 2011 and FY 2014. This is the same data as the previous slide, just displayed differently. You can really see in particular how state general revenue significantly increased from FY 2005 to FY 2008. Title V MCH block grant has been relatively stable over time, declining slightly over the years. An interesting trend since FY 1998 has been the rise in state dedicated funds through FY 2011, coupled with the decline and leveling off of the total number of state SBHC program offices. The sharp decline in SBHC program offices from FY 1998 to FY 2005 can be largely explained by the fact that a number of states were making very modest investments, in many cases pilot or demonstration projects of $500,000 or less. And when states needed to tighten their budgets, these programs could not survive. In addition, in a number of cases, these programs were intentionally meant to be one-time only investments. When we look at state program-funded SBHCs as a percentage of all SBHCs, we can see that this has declined slightly over time. In FY 1998, 56% of all SBHCs were funded by state program dollars, while this number has now declined to 40%. To make up for this difference, communities are increasingly turning to innovative financing strategies to fund SBHCs in their states. For this chart, we looked at the 14 states with 10+ years of investment in SBHCs. You can see that the percentage change of funding since FY 2002 varies widely. States such as Colorado, Michigan, and New Mexico have experienced enormous gains, while Massachusetts, Maryland, and New York have experienced significant decreases during this time period. This concludes the funding data from the State SBHC Program Office Survey, and I will now discuss some of the policy findings. Of the 18 states that fund SBHCs, all 18 collect data, including performance indicators, and all 18 staff a dedicated office or unit providing oversight and support to state-funded SBHCs. In addition, 16 set and monitor standards, and 7 define SBHCs in law or regulation. We surveyed the state program offices on a total of 24 performance indicators And the top 6 collected by the states include physical exams and physical exams, I'm sorry, go back. Sorry, we skipped ahead one. Okay. We surveyed the state program offices on a total of 24 performance indicators. And the top 6 collected by the states include physical exams and well child visits, enrollment as a percentage of student body, BMI assessment, annual risk assessments, users as a percentage of total SBHC enrollees, and immunization status. The most common SBHC data collected by states includes client visit data, operations, quality improvement, finance, and risk assessment. We asked state program offices to pick their top 3 concerns to growing and sustaining SBHCs, and these include establishing policies and mechanisms to maximize patient revenue streams, creating a sustainable financial model for SBHCs, maintaining strong partnerships with schools and local health providers, effectively addressing complex health and behavioral health issues of children and youth, ensuring continued support of SBHCs through public sector funding, and demonstrating the value and efficacy of SBHCs to health insurance and healthcare plans. This concludes the data highlights from the State SBHC Program Office. I will now move on to the findings from the State Medicaid Office survey. There are several key Medicaid policies covered in the survey. These include whether SBHCs are established as a provider type in code or regulations, the pre-authorization policy for SBHCs, and if Medicaid managed care organizations are required to reimburse and or contract with SBHCs. A total of 8 state Medicaid offices define SBHCs as a provider type, which is an increase of 1 state from the FY 2011 survey. In 5 states, SBHCs are waived from seeking prior authorization from the child's primary care provider or managed care organization for all Medicaid eligible services. And in an additional 5 states, SBHCs are waived from seeking prior authorization for a defined or specific set of services. Both of these categories saw an addition of 1 state since FY 2011. Lastly, 6 states either require MCOs to reimburse or contract with SBHCs. We also surveyed state Medicaid offices on the policy around mailing home and explanation of benefits. EOBs are of particular concern for adolescents and confidentiality for sensitive services provided by SBHCs. Slightly over half of state Medicaid offices surveyed do not send EOBs, while 27% do not do so for sensitive services to minors. The remaining 20% of states that either routinely send EOBs home, including for sensitive services, or do not know their state policy, indicates the need for further education of the barriers that EOBs can pose for adolescents' ability to access sensitive services. The most common conditions required for SBHCs to bill Medicaid are certification of the SBHC and licensure of the medical sponsoring agency. SBHCs in Connecticut, New York, and Maryland have the most conditions to meet before being able to bill Medicaid. All state Medicaid agencies surveyed recognize the role of SBHCs as providing preventive services, and a majority recognize SBHCs for their role in providing reproductive, EPSDT, early periodic screening, diagnosis, and treatment, and acute care as well. To recap the key findings, the number of states with dedicated SBHC investments has been stable over the past decade. State funding increased steadily through FY 2011 and dropped off slightly in FY 2014. States are continuing to remove Medicaid policy and payment barriers for SBHCs, but there is still more work to be done. I want to close out my presentation by pulling this map up again to highlight another interesting trend I mentioned at the beginning. If you look at the color-coded growth key, you'll see that some of the states in the darkest brown color who have experienced over 200% growth in SBHCs since 1998 are states that do not have an SBHC program office, as noted by the absence of a star. In states such as California, Florida, and Washington, this is in large part due to innovative local financing strategies that have allowed SBHCs to flourish. In Alameda and Los Angeles counties in California, in Seattle, Washington, and Miami, Florida, local public funds derived from bonds and special levies have helped grow and support SBHCs. In Ohio and Georgia in particular, state and local foundations have stepped up to support SBHCs, and in Georgia, Tennessee, and South Carolina, the expansion of telehealth programs has expanded the reach of SBHCs in rural parts of those states. In conclusion, state funding is critically important. It is our goal to establish an SBHC program office in every state. In addition to funding, a program office helps set high standards of care and accountability. And in the absence of dedicated state funds, counties and localities are forging ahead, developing innovative financing strategies and partnerships to grow and sustain school-based health centers. Thank you.
Thank you very much, Suzanne. At this point, we would like to ask attendees if you have any questions for Suzanne, please enter your questions in the chat box, which again is located in your GoToWebinar control window, and type in your questions. We would also like to know, are there policy topics that you would like to have discussed, would you like to have us focus more on in the future? If so, please enter your comments in the chat box also. While we give everyone a moment to enter their questions and comments, I would like to take a minute to talk about our membership at School-Based Health Alliance. School-Based Health Alliance works to improve the health status of children and youth by advancing and advocating for school-based health care. Our members extend and support our work. We ask you to please join us. We offer two options for membership, individual and organizational. Organizational memberships are $500 a year and include discounts on professional services and products, letters of support for grants, newsletters, and more. Individual memberships are $100 a year. To learn more and to become a member, please visit our website at www.sbhforall.org. Okay, right now we'll give everyone a couple of minutes just to enter their questions into the chat box that they'll have for Suzanne. All right, we're just going to read off our questions. Our first one is for Suzanne. Did your survey indicate whether SBHCs receive reimbursement from private payers?
So since we only surveyed the state Medicaid office around payment and reimbursement issues, we did not ask them about private payers. We did ask them about managed care and some of the different payment models for how school-based health centers are reimbursed by managed care organizations, but we did not ask about private insurance.
Okay, thank you, Suzanne. All right, our next question is, for states like California, Florida, and Washington, where growth in SBHCs have been rapid without the presence of a program office, what incentives would there be for them to establish one?
So that's a great question, and I think it's kind of tricky because we want to advance both messages at the same time. We obviously want to see state investment in school-based health centers, and we would love to see a state program office in every state. And we also want to encourage the growth of these really innovative financing models that we're seeing in different parts of the country. But we sort of want both, I suppose. So I think in answer to that question, I think in a number of places, for example, where school-based health centers are financed by local bonds or levies, taxes, et cetera, there's no guarantee that those will exist in perpetuity. So if that bond or levy expires and goes away, there's no guarantee with that source of funding, just as there's no guarantee with a state investment year after year. So I think it's important that we pursue all sorts of financing strategies because there's no guarantee that any one of them will last forever. But that's a great question.
Thank you. All right, our next question is, can you share a bit more about the relationship that SBHCs have with FQHCs and other community-based providers?
Yeah, so all school-based health centers are sponsored by a medical provider. So in a relatively small number of school-based health centers, about 10% across the nation, they are actually run by the school district. They serve as the medical sponsor, but in most cases, the most common medical sponsor types of school-based health centers are federally qualified health centers, which sponsor about 30%, maybe a little bit more now, about 35% of all school-based health centers across the country. Some, in addition to FQHCs, some other common sponsor types are hospitals, academic medical institutions, health departments, some nonprofits. So obviously the partnership with FQHCs in particular is super important because they are the most dominant sponsor type in our field, and that is definitely growing. And then I think in terms of other, I think you asked about community-based providers, it probably varies across school-based health centers, but they definitely have strong ties to other community-based providers who either come in and provide services, or the student is referred out to another provider in the community if that service is not provided directly by the school-based health center.
Okay, thank you. Okay, our next question is, what defined SBHC in the survey? The second part to this question is, what is it the presence of a clinic, medical provider, etc.?
In terms of how school-based health centers are defined in the survey. So at the start, in the instruction portion of the survey, we did include a definition of school-based health centers, and I can just read what that definition says. We said, for the purposes of this survey, school-based health centers are located in or near a school, are organized through school, community, and health provider relationships, are administered by a sponsoring facility such as hospital, community health center, university, or public health department, and provide primary health care services to children in accordance with state and local law, including laws relating to licensure and certification. And then we also said the term school-based health center does not refer to local education agencies, claims for health services identified in individualized education plans, IEPs, for special education students, or administrative claiming by local education agencies. So that was our definition, and if you would like to see that in writing, just shoot me an email and I can send you how we define that. As part of the definition of school-based health centers that we use, certainly that includes that they have a licensed medical provider. And in most cases, most school-based health centers tend to be run by nurse practitioners and nurses, but that's certainly a central part of the definition of how we define school-based health centers.
Okay, our next question is, will individual state level data be available?
So as part of our key findings from the survey, we are publishing an executive summary, which will include more in-depth data by state, and that should be coming out shortly. And then if folks are interested in data from their state beyond what we've made publicly available, if you reach out to me, I'm sure we could share some more information from your state survey. Yeah.
All right, our next question is, how does school-based health centers interface with school nurses in schools?
So that's an interesting question that I think varies widely in different school-based health centers across the country. But in general, I would say that there is a strong partnership between the school-based health center and the school nurse. In some cases, the school-based health center and the school nurse's office are co-located in the same space. So that allows for a lot of collaboration. There are obviously some health services that the school nurses cannot provide. It's outside of their scope of service. So though, students with those health issues definitely are referred to personnel in the school-based health center. But I think it's safe to say that a strong model includes a strong partnership between the school nurse and the school-based health center.
All right, we have another question. If the need for increased state programs was stressed, how is the national planning to work on that?
So I think in this context, our role is really to support state-level folks in providing technical assistance and support policy-wise for establishing a state program office and growing state funding every year. I think as the national office, I think our priorities from a funding point of view are more at the federal level, but we sort of see our role in terms of growing state funding really to support the school-based health center advocates in the field in those states, and in particular our state affiliate offices.
All right, we're going to read another question. While most data is QA, is there an outcomes data set being adopted?
So I think I understand this question, although I would encourage this individual to reach out to me directly, because I think I might need a little bit of clarification. But in terms of outcome data, that's sort of beyond the scope of the program office and Medicaid survey. I think we're most interested in what their policies are and what the funding data is. I think outcome data in general is certainly something that as an organization and as a field we're very interested in, but I don't think that we are really, that's really the goal of these two surveys in particular.
All right, we'll give a couple more seconds for anyone else that might have any more questions for Suzanne.
So as you're thinking of additional questions, I would also want to say that if there are policy topics that you would have liked to have seen more of a focus on, I'd be really interested in knowing that as well. So if you want to just type that in the chat box as a comment, that would be helpful as well.
Okay, like Suzanne said, you can also reach out to her and we'll definitely make sure we give everyone that information. We'd like to thank Suzanne so much for this very informative webinar of all the findings for each state. We do have a few questions for you, if we can just take a couple of seconds here. Our first question we would like to have, how well does the data presented in this webinar reflect your understanding of SBHC policies in your state? We just give everyone a couple of seconds to please respond. Three more seconds. All right, thank you. Our next question is, did this presentation meet your needs? We give everyone just a few seconds. Three more seconds. Okay, our next question is, how well did this presentation meet the stated objectives? We'll give everyone a few seconds. Okay, thank you. Our next question is, how likely are you to apply information from this presentation in your organization? We'll give everyone a few seconds. Okay, thank you. And our last question is, would you recommend this webinar to others? And we'll give everyone again a few seconds. Three more seconds. Okay, thank you everyone for attending today's webinar. And just a reminder, this presentation has been recorded. And again, we'd like to thank Suzanne so much for this wonderful presentation. It will be archived on the School-Based Health Alliance website at www.sbhforall.org within the next 3 to 5 business days. For any questions regarding the policy survey, please contact Suzanne at SMACKEY@sbhforall.org. Again, thank you and have a wonderful day.